Hello, everyone. Welcome back. Just want to do a quick thing. One of your classmates shared this story with me, so I appreciate that. Thank you guys for sharing interesting stories and stuff with me. But this was from March 31st, another overdose of loperamide. So pretty interesting story here. I mentioned that in the other lecture, I can't remember which one, but just people are unfortunately good at finding ways to abuse drugs. This is just from the Forbes, whatever. But scrolling down here, basically, if you take high enough quantities of loperamide, it's not good at crossing the blood-brain barrier. However, high enough doses, and apparently they put them in a blender and they take tons of tablets and stuff. So I'd encourage you guys to read about it if you have some free time, just for your future patients. But they also, interesting here. So there's also they are harnessing the power of drug interactions, which I wanted to highlight here. So there's some medications, for example, the CYP3A4 inhibitors. So we know those as the azoles, so itraconazole, some antibiotics, clarithromycin. And we have the 2C8 inhibitors, such as Zemfibrozil, are being given in combination with them to just it's kind of like a hack, I guess, like a drug hack. But yeah, like I said, since going to pharmacy school and getting out, I've stopped getting surprised at when people do things to get high and to abuse different drugs. So that was interesting. So I encourage you guys to read this article. But it's nothing, don't worry about it. It's not on the test or anything. I just thought it was an interesting article and irrelevant rather for the opioids, because loperamide is an opioid. So that is in the future potentially. They'll probably there has been some calls from the FDA to maybe change the way that these medications are distributed and like package size, quantities, and this may be something that we have seen before in healthcare. It was before most of y'all's time, but you guys maybe remember when you were little tiny kids, you could get pseudoephedrine over the counter without a prescription, and then the meth epidemic hit, and people were using the pseudoephedrine to make homemade meth, and then that became a behind-the-counter product. So that is now Oklahoma, Missouri, Texas, most states, I believe. I don't know if all the states, but most states now require that medication to be behind the counter. And then, for example, in Oklahoma, you're limited at how many you can buy at one time, how many grams per month, et cetera. And you have to have a state ID or some kind of federal or state ID, and it's been restricted. So it'll be interesting to see if loperamide goes the same way as pseudoephedrine. But anyways, that's just all FYI stuff. Don't stress about that for the exam. Speaking of the exam, we are going to get into the immunosuppressive drugs, cover the rheumatic disorder drugs, and cover the gout drugs. So these are not my favorite drugs, let's be honest. No, let's just full transparency. So I'll try not to sound too disgusted during this presentation. No, I'm kidding. But yeah, these aren't my favorite. So that's part of the reason I think of them as being those bad hombres, as Trump would probably call them. I don't know. But I just thought this was a funny video game thing. But yeah, so definitely this is, please study these for the exam. But it's, anyways, we'll just get into it. Yeah, you'll see what I'm talking about. There's a lot of, and by the way, I say bad hombres, there's a lot of bad side effects, a lot of drug interactions, they're great drugs, and sometimes they're life-saving and really, good things going on, but overall. So first off, we're going to start with the immunosuppressive. Notice the laundry list here. Some of these we've seen before. So we've talked about prednisone before, for example, methylprednisolone. We've talked about those. I don't believe we've talked about methotrexate yet, but that one is a drug that comes up in a couple different modules, depending on what we're talking about. But so most of these are going to be new drugs. Like I said before, we've already talked about the corticosteroids, so this is going to be kind of all review. I've had students ask me this semester, are we responsible for other things in other modules about the same drug? So for example, like with the diuretics, I want to make sure you guys are hitting those highlights. Definitely with these corticosteroids, please, think about the highlights when you are studying these. And if you need to, go back to your old notes, but, remember things like these do cause immunosuppression, which is why we're talking about here. But, the big adverse effects, the tongue-tied today, Cushing's-like side effects, for example. We're just talking about a little bit here, but specifically, we are just going to be talking this module about prednisone and methylprednisolone. Mechanism of action, again, this is review, so I won't spend too much time on it, but please read through that. And like I said, take home point with mechanism of action, it is going to suppress the immune system, which is why we're talking about them here. This slide is going to be maybe helpful when you're studying your mechanism of action. So just kind of a summary slide here. Uses, again, this is for the corticosteroids, can be helped with RA, which is abbreviation for rheumatoid arthritis, some other autoimmune diseases, and like you guys will hopefully remember from the pulmonary module, it can help with the treatment of asthma. Adverse effects, so they do, because of lowering the immune system, you can predispose to infection. And then, like I mentioned, the Cushing's syndrome. So please go back to your previous notes if you need a refresher and kind of review what that means. And those were definitely covered before in a couple modules, but those are definitely listed on other slides and other modules. So yeah, I'd encourage you guys to go back and study those and look at those if you need the reminder. Because there's always some students that, will say, hey, I already remember everything. Do I need to go back and study it? I'm like, well, no, I mean, if you already know it, that's no need to go back. But if you don't, you should. Other immunosuppressive drugs. So these are basically, in a nutshell, when the immune system, so the immune system is a great thing, right? And you'll be learning about this in pathophysiology and ICM, I believe. It's a great thing. It's life-saving, right? We all need it. We all die without it and have a lot of problems. However, sometimes the immune system can be overactive, quote unquote, and it'd be pathological. And so sometimes it is wise, or there's a medical rationale to prescribe an immunosuppressive drug. It's just basically because the immune system is going crazy, so to speak, or it's just, it's overactive, it's ramped up. And sometimes it's good to have these immunosuppressive drugs to kind of, to quiet down the system, I guess is a good way to think about it. Clinical uses, you'll notice there are a ton of uses here and which medications can be used for which uses. So yes, for studying purposes, I would look at this and just make sure that you're matching the disease to the drug. Because as always, for testing purposes, I want to make sure you guys know what these drugs are for and what they're not for. Azithromycin is the first one here. Pharmacokinetics, as usual, just go ahead and this is going to be FYI. Just note it's a rare but serious. There can be basically certain genetic types of people can have problems metabolizing it, but like I said, FYI, for testing purposes for this exam and for my course, don't want you guys to focus too much on the kinetics here. Mechanisms of actions, this is a big one. Initially, it looks pretty complicated, but you will note here, please, that highlight the exact mechanism of the immunosuppression is unknown. So this is one of those that is not fully elucidated. So we have our best theories here. So just look through it. Definitely know that the metabolites are incorporated into replicating DNA and halt the replication. So they do know that they're doing that. But anyways, as far as the specific why they cause immunosuppression, it's not completely understood. Adverse effects, you'll notice this is why I started off by saying these are bad hombres. Bone marrow suppression can be an issue, and at higher doses you have issues here, some GI adverse effects, skin rashes, fever, and then rare but serious of the liver dysfunction can be there. And then you have to be mindful of the liver dysfunction when you're talking about some other drugs. So specifically allopurinol, which we haven't talked about yet, is a gout medication, can increase the risk of some of these adverse effects. So uses, autoimmune diseases, please refer back to that chart if they have any specifics there, and then kidney transplantation. Cyclophosphamide. So this mechanism of action is elucidated, I guess. So this is the most potent immunosuppressive agent. It alkylates the DNA, so messes with DNA. It's always good at destroying stuff, but it destroys proliferating lymphoid cells in addition to some quiescent cells. So this will be beneficial. You'll see it when we talk about our cancer drugs, also autoimmune diseases and organ transplantation. Methotrexate, so this is a big one. I'm definitely going to have test questions on this. So you can put a star by this drug. And I'm saying that, but I'm also saying study the other drugs. So, because I know after this someone listens to this lecture, they're gonna be like, you said put a star by methotrexate, but you didn't say put a star by cyclophosphamide. So please still study cyclophosphamide, still know that what it's used for, its mechanism of action, and its use is also on that other table. But I'm saying put a star by methotrexate because I'm guaranteed test questions from it, and part of the reason is because you see it a lot in a lot of different of your specialties and subspecialties. General practitioners use it. It's ubiquitous, and so that's why I want to make sure you guys are definitely studying methotrexate. Versus the cyclophosphamide is important. However, it's more of niche. It's kind of in the corner of healthcare in that you may never come across it. You may never, prescribe it. It's going to depend on, definitely if you work with a oncologist, you might be prescribing it, might be seeing it. Organ transplantation, if you're working, with a physician that deals with those patients with organ transplants, that may be something, or you may see it outpatient if someone had an organ transplant, maybe, but versus methotrexate, I feel like is something that you guys will come across a lot more. So that's what I'm saying, put a star by it. So hopefully that's clear, but if not, just email me. You guys are good about emailing me, so just email me if you have any specific questions about why I said methotrexate is important for you guys to study. I was going to say methocism of action instead of mechanism. I was combining methotrexate and mechanism. All right, so anyway, so mechanism of action. This one is a folate antimetabolite that inhibits DNA synthesis, repair, and cellular replication. So that's kind of take on point there. Also, please note that it is cell cycle specific for the S phase, which that'll be more relevant when we go and talk about the oncology medications. So things like that will definitely be testable later on during when we cover the oncology drugs. But it won't hurt to start studying it. It'll be one of those things that you study it now and then you'll see it later. I see it again later. So the other thing that's just kind of important for the mechanism of action, the actively proliferative tissues, so things that are growing quickly are more susceptible to the effects of methotrexate. So that is important with its uses and also with the adverse effects. So I think you see that anything is actively proliferating, that just means fast growing tissues. Mechanism of action continued, and this is more related to specific uses. So with rheumatoid arthritis and disease like that, they're not sure exactly why it works. Psoriasis, again, it's not fully elucidated as far as why it's effective. They think it's because it attacks the epithelial cells. In Crohn's disease, they think it may have an anti-inflammatory activity and immune modulation. So some of these things with mechanism of action they're still being studied basically, but this slide here has some good stuff about what methotrexate is doing. Uses, so like I mentioned, you will be seeing this drug again in the oncology lectures. So lots of uses here. For this exam, don't stress about memorizing every type of cancer for methotrexate, but please know, and please please make sure you memorize that methotrexate has oncology uses and quote-unquote non-oncology uses. So this being the MSK module, I do want you guys to memorize and study the non-oncology uses. And again, just to repeat myself to make sure, but hopefully I'm clear. And then just know that there are oncology uses. So just know in general that they can be used for all of these things, but you don't have to memorize breast cancer, head and neck cancer, T-cell lymphoma, et cetera, et cetera. Just know that they can be used for cancer, oncology uses, and then the non-oncology uses I do want you to look at and specifically know methotrexate can be used for psoriasis. Methotrexate can be used for RA with the caveats, and please read the guideline recommendations and everything. And they can be used for the idiopathic arthritis, juvenile idiopathic arthritis as well. So yes, please look at those specific uses. Off-label, again, look at these, read through them, and just know that you're going to be seeing these again in different modules, but you don't have to stress for this module exam about memorizing these. So hopefully this will help you guys studying a little bit. But you just go through them. You are going to see it again, OB-GYN, so abortion, ectopic pregnancy, right? GI, Crohn's disease. We talked about cancers already. Lupus. So yeah. Again, read through it at least once. please. And then I can't make you guys do, you can do whatever you want to do. You guys are adults, right? But yeah, I would recommend, I guess I should say, read through these at least once. But for testing purposes for this exam, please, you could put a star by this slide. The non-oncology uses I want to make sure you guys know about for the MSK exam. Adverse effects. Oh, by the way, MSK, I think I've told you this already, but MSK is my abbreviation for musculoskeletal module. So when I say MSK, that's what I mean. But anyways, so that's a side note. I think I've said that before, but just so everyone, we're on the same page. I don't want anyone being lost and trying to look up what MSK means. All right, adverse effects, definitely put a star by here. Want to make sure you guys know this. Macrocytic anemia caused by the folate deficiency. So very important. Part of the reasons too why methotrexate a lot of times will be prescribed with folic acid or some sort of supplement, folate supplement. So definitely want to make sure you guys know that. And also too, note that it's not microcytic anemia. So I believe you guys have already been over the differences in ICM course, but the reason I mentioned that, it's kind of nitpicky and I don't like those types of questions for my exam. However, on a board review, I saw where microcytic and macrocytic were answer choices for methotrexate. So, make sure you're paying attention to which type of anemia. So sometimes it's important, and at other times it's just, anemia. But anyways, bone marrow suppression, rare but serious. Pulmonary fibrosis, rare but serious. Hepatotoxicity, very serious. You can put a star by that. Teratogenic activity, put a star by that. The FDA no longer, quote unquote, uses the pregnancy categories, but it formerly was a category X. So definitely absolute contraindication in pregnancy. So please make sure you're studying that. Contraindications, again, please pay attention to these for studying purposes. As per usual, we have the known hypersensitivity, right? That's breastfeeding, so related to the absolute contraindication. So not only for pregnant women, but also for breastfeeding women. And then additional contraindications. So you notice pregnancies there again. Alcoholism and alcoholic liver disease and other chronic liver diseases. So that is related back here. Hepatotoxicity, like I said, is very serious. So you need to be thinking about the patient and as far as their liver function, their liver health. Other immunodeficiency syndromes, blood dyscrasias. So that's related to these macrocytic anemia and the bone marrow suppression. So please make sure you study those. Boxed warnings. Oh my goodness. So please study these as usual. I like you guys to study these for exams. And just note that there are a lot for methotrexate. Some of these, like appropriate use, read through them, but, intrathecal and high dose therapy, again, those are, I would say, less common, but definitely pregnancy, bone marrow suppression, renal impairment, hepatotoxicity. Those are big ones, and I would want you guys to definitely make sure you're taking that with you when you go into your rotations. More boxed warnings. Interesting, secondary malignancy. So you'll note when we study the oncology drugs that unfortunately a lot of these oncology drugs are good at killing cancer, but then they also can be good at causing cancer. So anyway, so these are a little bit more GI toxicity. These are a little bit more common, I guess, box warnings. They are still box warnings, so definitely read through all these. Make sure at least read through them once. And you're experienced. I was experienced with an experienced physician. Make sure you're exposed to them. And so opportunistic infections there. Just note that the reason I'm highlighting that is just with all these immunosuppression medications, there's a potential for it. Some have the box warning, some don't. But methotrexate is basically, it's good enough of an immunosuppressive agent that you can have fatal opportunistic infection. So this is where you get your some of these bugs that don't affect normal, quote unquote, immunocompromised patients. You'll get some of these weird infections with people that are on methotrexate. Okay, so a lot going on there. But anyway, so yeah, please, like I was saying, for studying purposes, hint, guaranteed at least one test question on methotrexate. Okay, I'm going to say that. I'm going to give you guys an Easter egg. It was Easter recently. No, but I gave you guys a big hint there just because this MSK module is pretty crazy. And like I said, I don't really like this module. I mean, not this. I like the module. I just don't like this presentation. So I'm trying to make it easier for you guys because it makes it easier for me too, right? So you guys scratch my back, I scratch your back now. Okay, cyclosporine. This is another one that you may come in contact with. This one, pharmacokinetics, I normally say don't worry about, but this does talk about drug interactions, so I do want you to study drug interactions. So cyclosporine is one that you need to associate with drug interactions. So specifically, you have a risk for nephrotoxicity and seizures because of cyclosporine toxicity. You notice it's a lot of different drugs here. You don't have to memorize explicitly these examples I'm giving you, but please note when you're studying that cyclosporine is a medication that you need to be concerned with drug interactions. Mechanism of action. Okay, this is another complicated mechanism of action. Please do your best to go through it and study it. I simplified it here. Basically, it inhibits the production and release of interleukin-2 and inhibits interleukin-2 induced activation of resting T lymphocytes. So that's a take-home point. The bigger global take-home point, what does that mean? Because this is simplified from this. You're welcome. No, but the more simplified, the most simplified I can get, kind of the most distilled I can get, take-home point, this medication causes immunosuppression. So this is what all this means with the interleukins 2 and interleukin 2 induced activation of resting T lymphocytes. What does all that all mean? Your immune system is suppressed, which is desirable when you're giving this drug, or hopefully it is. I mean, hopefully you guys are giving this drug for appropriate reasons. Adverse effects, again, messy drugs, bad hombres, nephrotoxicity. Please put a star by that. And you notice up here, we talked about that, the nephrotoxicity is part of the cyclosporine toxicity. Well, it is the most common adverse effects, and it's virtually all. So 99% of your patients are going to have potential and have issues with nephrotoxicity. So again, like I said, this is a dirty drug, quote unquote. And by the way, too, I've had students ask me in the past, I'll sometimes say dirty or messy or whatever. I just mean that it's just, undesirable adverse effects is what I mean. I don't, and I'm a literal person, so sometimes I'm like, it's dirty, like it smells bad. No, metformin tablets do smell bad, or at least the ones I've smelled. I don't know which ones you guys have smelled, but this one, I don't know if it smells bad or not, but I mean dirty in the sense that, nephrotoxicity is going to happen. Clonidine is, you'll remember from the cardiovascular module, hopefully, that will minimize nephrotoxicity, so they will be given in combination. And then related to drug interactions, you have to be concerned with the additive effects of nephrotoxicity. So anytime you're giving anything else that already has an issue with nephrotoxicity, plus this medication, it's almost a guaranteed kidney killer. So that is something that you need to be mindful of. In particular, too, I'll highlight here, NSAIDs are on the list. So those are over-the-counter medications, right? So your patients who are on this medication may have access to that without a prescription. So that is really can be problematic, and definitely the patient needs to be warned, counseled, etc. if they're on this medication. That over-the-counter, some of the over-the-counter medications can be life-threatening. I mean, if you kill the kidneys, it's no bueno, as Trump says. Bad hombres are no bueno. So these NSAIDs are no bueno. No, I'm kidding. Sorry, I couldn't help myself. But yeah, so this is just, all joking aside, nephrotoxicity, definitely want to be concerned with. Hypertension is another one. Look, up to 53% of people on this medication, hypertension. Hyperglycemia can be an issue if they have diabetes. Seizures, I mentioned too, that's part of this drug's toxicity, nephrotoxicity, and increased risk of seizures. So definitely something to be mindful of if a patient's on another seizure medication, or if they have seizure disorder, or if they're on anything else that can lower the seizure threshold. So we're getting kind of towards the end of Pharm 2 now. So hopefully you guys are starting to see some patterns here as far as where you have to be concerned with drug combination. And then rare but serious increased risk of cancer, squamous cell carcinoma. So this drug, like I said, is not, it's a messy drug. Box warnings, again, just part of its messiness. Please read through these. Lots going on. Notice too, it does say experienced physician. So I'm hoping and I'm assuming that right out the gate, right when you guys are freshly licensed, you have your nice and clean, good smelling license, right, fresh off the press. I'm hoping and assuming you guys won't be prescribing this right away, like your first month out as with your license, and you're just like, yeah, let's give them some cyclosporine. Why not? No, but so this is definitely, you're going to be working with specialists when you prescribe this, and but definitely pay attention to it, study it, because even if you aren't with a specialist, even if you end up with a general practitioner or you end up inpatient, you sometimes see these drugs pop up, even though it's something that you're not prescribing. It is something that you need to still be able to think about with your management. So, for example, they're in their hospital. you're seeing them, they're your patient, they have a bad infection, they're on vancomycin, they're already on this medication, you need to be thinking about protecting their kidneys, right? Or that you need to be mindful of the nephrotoxicity. So anyway, so don't let that deter you if you see experienced physician. I've had some PA students in the past ask me about that. They're like, well, I don't have to worry about it because it says only healthcare providers experienced in immunosuppressive therapy. So it's like, I'm not going to have to deal with this, which is true to a certain extent, that you won't, like I said, you won't be prescribing it right away. And it maybe isn't something that you're, on rotation is going to be completely left out there on your own. However, you may still come across these medications because of patients that you see in other settings that happen to be on it, and they're prescribed the medication from another physician. And it's also potentially on my exam, and it's also on your board exam. So there's some other reasons to study it too. But so box warnings, please go ahead and read through those. Uses here, so transplant rejection, both prophylactic and chronic treatment, and then may be used, but probably last line for psoriasis and rheumatoid arthritis. I would guess if you're going to see this, it'll be more for organ transplant rejection, but that's just my guess. I don't know. It'll be interesting to see what you guys see out there. Next up, we have tacrolimus. It's always kind of fun to say. For me, I don't know, pharmacy nerd, whatever. Don't judge me. It's a macrolide, interestingly enough, derived from a fungus. That's just kind of FYI. For classification purposes, though, I wouldn't classify it as a macrolide, and so it's technically correct, but for your studying purposes and for my exam, go ahead and still classify it and think of it as an immunosuppressive drug. But anyways, it is going to be used for, it's like cyclosporine, this cyclosporine. Sorry, I've had like problems talking all day. I'm sorry about this, guys. It's like the kinetics are similar. It is more effective though in for organ transplant, so that's interesting. The other benefit too is that it typically isn't as nephrotoxic, so that's another huge advantage of tacrolimus versus the cyclosporine. It is still, a drug you need to be careful with, so there are still some box warnings. You notice the malignancies and serious infection are there. Mortality is there, experienced physicians there again. However, overall, not as many box warnings to worry about. Next up, we have the mycophenolate, Mofetil, which I need to look up the brand name, but the brand name is a lot easier to say. It's basically related to MPA. Take-home point. So this MPA inhibits purine synthesis, so take-home point is immunosuppressive, and is used in combination with the cyclosporine and corticosteroids for transplant rejection. Some adverse box warnings here related to adverse effects, serious infection, malignancies and serious infections, embryo fetal toxicity too, so it's a little bit different, but not as many as we saw with some of the other drugs, like with methotrexate. Abatacept. So this one, just go ahead and read through this. This one can be used, not necessarily first line, but it can be used for rheumatoid arthritis. But it's just kind of a complicated, just read through that one. I wouldn't spend too much time stressing about that drug. And then just look at the uses if there's any uses on that other table that I mentioned. Anti-TNFA agents. So these are listed here. All of these, because they're good at suppressing the immune system, can have an increased risk for opportunistic infections. So a couple of these are monoclonal antibodies. We have Intercept, Infliximab, and adalimumab. First off, Intercept. Here is the mechanism of action. Here, be used for arthritis, for example. This one is injected sub-Q, Infliximab. Monoclonal antibody, like I said, because it ends in MAB. This can be used for RA in combination with methotrexate, and then maybe be beneficial in Crohn's disease. And we have the last one here. Just go ahead and read through this. Again, can be used for arthritis, Crohn's disease, maybe, and then maybe also be beneficial for psoriasis. And just go ahead and read through this as well. next up we have ATG. This is anti-thymocyte globulin. This will help also with organ transplant rejection. Please read through it. Then we have OKT3. And again, these drugs I'm kind of going through quickly. They're going to be really rare. I wouldn't stress too much about them. Don't spend a ton of time on them. I'm just having here for completeness sake. These are really niche drugs you're going to maybe see, maybe not. It's just going to depend on if you end up with organ transplant rejection. And even in the pharmacy world, this is like a subspecialty thing. So these drugs are, you have to go to residency and then do a fellowship, and it's kind of crazy. But okay, T3, Mironamab, CD3. I don't know if I'm saying that even correctly. Then we have the chimeric monoclonal antibodies, and the chimeric just means that they are mouse-derived and human-derived, is what that means. And we'll be talking about these more when we talk about the oncology drugs. So you'll be seeing some of these again there. But these again are transplantation drugs. So just overall with these transplant ones, I mean, obviously, like I spent some time on methotrexate. The ones I spent time on, but these ones I'm going through quickly. Don't spend a ton of time on and don't stress about them too much. Next, we have the Rhody immune globulin. We'll talk about more in depth when we are in the OB-GYN module. So stay tuned for that. Don't stress about it too much there. It's also can be beneficial for ITP. So here we go. Here's a summary table here. So definitely steroids, put a star by there. Yeah, this next one here, I mean, like I said, read through it and look through them, but don't stress too much about it. Cyclophosphamide, go ahead and put a star by that one. Make sure you spend some time on that. Cyclosporin, tacrolimus, put stars by those. Want to make sure you spend some time on that. And I'm talking just for my testing purposes. So again, all this stuff is potential for your board exam, so it's not going to hurt you to read through it. Methotrexate, definitely put a star by that. Want you guys to look at those. So you'll notice there's a lot of those that I didn't say to. They're in there. They're in the slides. Read through them at least once, but don't stress too much about them. Next up, changing gears here a little bit, anti-arthritic drugs. So we'll notice some that we've already talked about here. We talked about the NSAIDs in a previous lecture, in two previous lectures, COX-2 inhibitors and the corticosteroids we've talked about. And then we'll get into the DMARDs, which are disease-modifying anti-rheumatic drugs. Okay, first off, we're going to talk about the NSAIDs and COX-2 inhibitors. This is all review, so I'm not going to spend too much time on it. And this is just showing mechanism of action as far as where are some of these medications specifically working. COX-2 inhibitors, and like we've already been over this before, but basically they're pulled from the market, safety issues, so please refer to other presentations for that. Same thing with the steroids. There are some of these, so for specifically prednisone, methylprednisolone, can be used short-term for acute RA. They do help, but they will not stop or arrest the disease process, so they typically are not used chronically for rheumatoid arthritis. And part of that reason, too, that they're not used chronically, you hopefully will remember from previous lectures, is because of their adverse effects. And when they're chronically administered, so you have these exogenous corticosteroids that they basically trick the body into producing their own, and it's a big complicated mess. So typically, when you are going to use these, it's be acute. So please make sure you note that and highlight that on these slides. All right, DMARDs. These are ones we haven't really talked about yet. I'm kind of lying here. We did talk about methotrexate a little bit, but in previous lectures. So these all help with arthritis. They counteract joint inflammation and destruction, and they help slow the progression of RA and also lupus. Methotrexate. So this is going to be a lot of repeat. We just saw this here, but as usual, please just go ahead and read through it again, or make sure you're studying it. And like I said before, I want you guys to put a star by methotrexate to make sure you definitely are studying it for testing purposes. Contraindications, we've already seen this. Box warnings, we already saw that. Immunosuppressive drugs. So we talked about some of these before, but some of these can be beneficial when helping with rheumatoid arthritis. But again, these will typically not be first line. These are things that are going to be reserved to later on, and I believe in ICM you guys will be covering that as far as the treatment management of patients with rheumatoid arthritis. Anti-malaria drugs, so this is kind of interesting. They don't really know why they work. My guess is, and I think this is from pharmacy school professors, they said this too, I'm not that smart, is that, people who had rheumatoid arthritis got malaria. They were treated with these anti-malarial drugs and their arthritis got better. So then they were like, hey, why not use this for arthritis? So anyways, they're not really sure exactly why it works for arthritis, but it's one of those that, you may still see. Again, it's usually adjunct to NSAIDs. And so anyways, yeah. Adverse effects there, just please note those two are rare but serious. Gold compounds, so again, kind of rarely used. Historically, these were more popular, but these, since the 80s, they haven't been used as much because there's been newer therapies that have come out that are more safe, efficacious, and less costly. So some of these are pretty expensive. You notice both of these do not have generic medication or generic equivalents available right now. And then also related to its safety, notice some pretty nasty adverse effects here. So renal toxicity, blood dyscrasias, those are both can be pretty problematic for the patients. So these have fallen out of favor since the 80s. But you may still see them in other countries. I had a student last year from India. He was a IMG international medical graduate. He got his MBBS over there, and he was saying that he would see it and he'd use it, prescribe it every once in a while. So I don't know, and I don't know what part of India or whatever, but that was just interesting that he brought that up. That he's like, oh yeah, but here in the U.S., really since the 80s, like I said, they've kind of dropped off and not as favorable as they once were. Penicillamine, so this is an oral chelating agent. Because of that, it should not be used with the gold compounds, but it can be used for a few different things. And again, this is resistant, kind of last line adjunct for rheumatoid arthritis. And then just basically because there's adverse effects, it's not as safe as some of the other medications. Sulfasalazine, so this one can be used for juvenile RA and rheumatoid arthritis. But please go ahead and read through this, and please read through the note as well. Sulfasalazine can also be used in ulcerative colitis. So this is hopefully remember from the GI module. And some other off-label uses there. Contraindications, so you have to be concerned with hypersensitivity. This is one that technically has an issue with the sulfa allergies, quote unquote, so please note that. And however, like I've said before, newer evidence shows that this may just be a hypothetical risk. And so it may be okay to go ahead and still prescribe this if a person has a true hypersensitivity type 1 reaction to sulfonamides. Even though they're chemically, they have the sulfonamide chemical structure, they maybe still be considered to be safe, is what I was trying to say. And this is just more on that sulfa allergies. Just going to read through that. And so like I've said before, this is where you can still see some of these prescribed for patients where they do have a true hypersensitivity, but it's just going to depend on your patient, how cautious you want to be, how bad was their reaction, how frequent have they had that reaction, when was the last time they had their hypersensitivity reaction, etc. It's all going to kind of depend. And then how bad do they need the medication as well? Can you give something else other than sulfasalazine? I don't know. Here's a good summary table here. So as always, please look at the clinical applications, adverse effects, and contraindications. Gout treatment. So these are all going to be new drugs with the exception of the NSAIDs. So in the methicillin we've seen before. We talked about the NSAIDs before. This is just a little bit of background for you guys, but just know that there is primary gout and secondary gout, and I believe you'll be covering this a lot more in detail in ICM, but this is just kind of a little intro. And then just know too that secondary gout can be made worse or be caused by some diuretics. This is related to the GU module, but some thiazides, furosemide, and ethylquinic acid. I don't know if you guys remember from their adverse effects, but they can actually make gout worse or sometimes cause gout. Again, just overview here, stuff you'll be studying and covering in pathophysiology, tested on. This may help, though, as far as mechanism of action. So you notice the allopurinol is hitting the xanthine oxidase, because it's a xanthine oxidase inhibitor. But anyways, and so you'll notice where some of these other drugs are working. So for acute attacks, the colchicine can be beneficial for that. In addition, the indomethacin and other NSAIDs are typically going to be first line, specifically naproxen and indomethacin. I put the dosages here, don't worry about those. And then they typically keep the patient on the NSAID for about a week, so 5 to 7 days. Like I mentioned before, aspirin is a different type of NSAID. So it's a prototypical NSAID. It is an NSAID, so for studying purposes, make sure you... However, it's a little bit different. So we've gone through that before in other lectures. I won't go. One of the ways it's different is it actually has paradoxical effects on the serum urate. So basically, what does that mean? Take home point, aspirin can make your acute attack worse. So NSAIDs, yes, and colchicine, yes, are good. But just please note to avoid aspirin. And then for your NSAIDs, your first, second line are going to be your naproxen and indomethacin. Colchicine. So this is an interesting medication in that it has a really niche use, in that it just helps with the reduction of pain and inflammation of acute attacks of gouty arthritis. So this is for patients who cannot tolerate steroids or NSAIDs with an absolute or relative contraindication. And then this is patients initiating anti-inflammatory gout flare therapy within 24 hours of symptom onset. Also used for prophylaxis during initiation of anti-hyperuricemic therapy. The reason I put that in all capitals because that's going to be probably your number one kind of where you see it being used. So that's why it was on all capital letters there. I'd done this lecture, I typed this up last year and I was like, why did I capitalize that? But anyways, I should have just bolded it, but whatever, it's already capital. So that's why that's here. Adverse effects, generally will tolerate GI adverse effects. So, and please go through the mechanism of action there. And then just note, technically for classification purposes, this is not an analgesic or it's not a uricosuric agent. So that's interesting to note there for classification. It is an anti-inflammatory agent. And then, like I said, very niche uses, and mainly it's going to be used for prophylaxis during initiation of anti-hyperuricemic therapy. Indomethacin and other NSAIDs. So these are also effective. So not only they can help with acute gouty arthritis. Now, acute gouty arthritis. Some other uses here we've seen before. So the OB-GYN mentioned, which we talked about before, and then OA as well, or osteoarthritis. Prevention of acute attacks. The goal is to decrease the serum concentration of uric acid. So we have some strategies here. The probenecid and the lesinurad are considered the uricosuric drugs. Probenecid, first off. So this blocks the resorption of uric acid, the prostoperitoneal. So basically you excrete more uric acid. Also inhibits the renal excretion of penicillins and other weak organic acids. So please note that and make sure you pay attention to that for drug interactions. Also related to its uses. So because of this inhibition of excretion of penicillins, you may see the probenecid being given in combination with penicillin to prolong penicillin serum levels. That's interesting. Use hyperuricemia. That's why we're talking about now. Gouty arthritis. However, probenecid is not effective in the treatment of acute attacks. So this is not for those acute attacks. So please note that. I had students in the past get that confused. And so it is going to be for their chronic condition and the hyperuricemia. And then, like I said, maybe in combination with penicillins to help prolong their serum levels. Lesinurad, which is Zurampic is the brand name. So this one also lowers serum uric acid levels and also helps increase the secretion of uric acid. This is taken in combination with the XOI with the xanthine oxidase inhibitors, which is allopurinol. So it's taken in combination with the allopurinol to help further reduce serum uric acid levels. It does have a couple box warnings, so it is a kidney killer, nephrotoxic. So make sure you put a star by the box warnings. As always, make sure you study those for my exams. And then appropriate use, that this should always be used in combination with a xanthine oxidase inhibitor. So for, like I mentioned, allopurinol, for example. Speaking of, great segue there. I forgot that this was next. Mechanism of action. It is an XOI. It is a xanthine oxidase inhibitor. Xanthine oxidase inhibitor, XOI. And therefore, it inhibits the synthesis of uric acid. So this helps with the prevention of primary and secondary count. This is going to be your first line agent for urate lowering therapy. Also, please note too that it's not for the acute; it's for the chronic condition. Adverse effects. Please read through these. These are the most common adverse effects. So this is interesting in that and this is more of a problem again historically, but allopurinol can actually make the gout worse acutely. And so this is why they recommend, so definitely go and read through all this, but this is why they recommend the colchicine or an anti-inflammatory, so NSAID, to help with the suppression of the attack of the gout. It's less common now because of lower dosaging. So historically there were higher dosages of allopurinol, but so they do recommend, this is a medication they recommend starting at a lower dose and then go ahead and give it in combination with the colchicine and or the NSAID, anti-inflammatory agent. And then here is the rationale as to why. So you look here and it says, allopurinol can actually cause an acute attack of gout. So that's where you have to give colchicine or an NSAID with it. And this is the reason why. So it's basically that there's some disruption of the crystal deposits, and then that disruption basically causes an immune response, and it just makes the person feel like they're having an acute attack. So anyway, so yeah, hopefully that's clear. But that's the rationale and part of the reason why the colchicine anti-inflammatory agents are given in combination. And then it's also a reason why you want to start at a lower dose. And historically why they used the higher doses and had more issues with the acute gout attacks with allopurinol. The other xanthine oxidase inhibitor we have is the Uloric, brand name Febuxostat. Kind of a harder name to say. Uloric's a lot easier to say. But this is second line to allopurinol. So this is patients that are for every reason intolerant or unable to take allopurinol. Then you go to this. They are both in the same category, but allopurinol is older, kind of cheaper, better studied, and so it is considered first line. Other issue with the Uloric is that there was a safety alert in November 2017. So go ahead and please read through that. But this is another reason why it is not considered first line, and that you should try the allopurinol first before going to this. So, and specifically increased risk of heart-related death with this medication. Elitech is rasburicase. I have to slow down to say that one. Rasburicase. Elitech is a lot easier for me to say. But this one is a recombinant form of non-human urate oxidase. So the mechanism of action, it converts uric acid to allantoin, which is excreted by the kidneys. So this is used for hyperuricemia associated with malignancy. So again, not just going to be your plain vanilla gout. So kind of a niche use on this one, and probably you're going to see with your oncologist prescribing this and using this one. Adverse reactions, so hypersensitivity reactions, anaphylactic shock, and anaphylactoid reactions. Also a messy drug too as far as its boxed warning, so please read through those. And then here is a good slummery. Man, I can't talk today. I'm sorry guys for all my tongue-tiedness. I'm drinking hot tea too, and I'm doing all my normal stuff. I think I'm just kind of tired today, and I don't like these drugs, so sorry guys. No, it's not that I don't like. I think I'm just too tired today, and that's why I'm having trouble talking. But anyways, that was the last one. So please, as always, look at that last slide. Sorry, I kind of went by it kind of quick. But yeah, please look through this slide. Make sure you read through the clinical applications, adverse effects, and contraindications. As always, thank you guys for your time and attention. Thanks for putting up with my tongue-tiedness today and tongue-tiredness today. Please feel free to email me any questions, comments, feedback you guys have. And I will talk to you guys later. Thank you guys. Bye.